But Gildas, you started the webinar.
No, I didn't start anything.
Oh, you did.
Oh, of Ebola. However, there are two kinds of populations in which we are in close monitoring, and one is those illegal mining population, which is cutting across. And also we are aware on another population in which is actually engaged in the smuggling of the fuel and oil from Angola to actually Kasai province. And is a reason we are tracking these population movements. And also we are tracking what is happening in the major airports. And we've already talked with the Director General of Ethiopia Public Health Institute to see if they have enhanced readiness capacities at the airport. As you know, in 1 week time, we'll have UNGA 80 in the New York. Therefore, every country in Africa to send a delegation, and we have to track actually on that. So we are now collaborating with the Google, in which if we see, we'll be able to come up with the modeling and imagery of the population dynamics in the region. Therefore, we hope the outcome of the modeling, it will tell us if the risk remains moderate or we have to worry. On the last action, in which is critical for us, is the readiness itself. And I'm glad our team here, Charles, Ibrahim, and others have been really step up on the readiness assessment across country. We will be collaborating with other partners who will be interested to come on board on that. And in addition to readiness assessment, our expectation is our neighboring countries will have capacities at the ports of entries and also capacities to see if we have isolation capacities, strategic stockpiling, and others. As a result, I'll stop here, Njuguna, but I'm glad to see the elevated interest of our member states, and I'll be here to hear if we have any queries related to the readiness and the risk of international spread in the current Ebola outbreak. Merci à tous.
Thank you. Merci beaucoup, Dr. Dick Chamla, for the opening remarks and highlighting the situation in our region and the threats that are there, the risks that are there. I think the good news, Dr. Dick, that has just come in a few hours ago is that the results are negative for the Liberia suspected VHF from the IP Dakar. That's what they have. We have received that information just a few hours ago, but they will still go on with the metagenomics and we'll have a full report. So I think we hope, we keep our fingers crossed that things are good and they will not have another EVD outbreak in West Africa. Yeah, thank you. So thank you, Dr. Dick. So I think we will need now to go to the technical presentation, and the numbers are increasing. Now we are at 300, we are over 320. This is showing that there is a lot of interest among our member states, among our partners, and also the country offices of WHO in the region. So it's my pleasure now to invite Dr. Esther Mwanguzi, who will be presenting the epidemiology of the FVD and the status updates in the region. Dr. Esther, I hope you can hear me well. Over to you.
Yes, Dr. Charles. Good afternoon, colleagues. Good morning, depending on where you're joining from. My name is Esther Mwanguzi. I'm an epidemiologist in the WHO Regional Office for Africa, and I will be taking you through a brief update on our current, the ongoing Ebola outbreak in Kasai province. Next slide, please. So what we have for now is as of the 14th of September. And so the update that I'm going to give is as of that date. That is the latest situation report that we have from the Ministry of Health. So colleagues who may be in DRC and have more updated information, that may be you have, but we have not yet received this in the regional office. So just a brief of what happened with the presumptive index case. On the 4th of September, the Ministry of Health of DRC declared an Ebola outbreak in Wulape Health Zone in Kasai Province, following tests conducted at the INRB in Kinshasa. For our information, this is the 16th outbreak of Ebola in DRC. And so the presumptive index case was a 34-year-old female who was pregnant by the time that she presented to Wulape in the General Hospital on the 20th of August. She was bleeding by the time she presented to the hospital, and she died on the same day in the hospital, was attended to. Of course, the health workers did not suspect EVD, although she was bleeding. And she died from, she initially presented to another facility and then came to Wulape General Hospital, where she died from on the 26th of August from multiple organ failure. And she was bleeding from all body orifices. Just for our information is when the laboratory did the testing, they also did genomic analysis. And so this outbreak is a zoonotic spillover event and is not directly linked to any of the previous outbreaks. I wanted us to note that. Next slide, please. So I will give you, yes, I will just highlight key timelines on events that happened before the confirmation and after the confirmation of the outbreak. So from investigations, the presumptive index case started experiencing signs and symptoms on the 10th of August. And on the 20th of August, she came to the hospital, and this is when she died. Apologies that the dates that we have keep conflicting because we are still investigating, and we have quite a lot of information that we are trying to harmonize. So if you see that the dates may not be very, very consistent, you will forgive us because we are still investigating, and every day we receive new information, and so we keep populating and harmonizing it. So between the 22nd and the 28th of August, 3 of the health workers that attended to the index case developed signs and symptoms, and they died. And on the 1st of September, the Ministry of Health received this alert and also alerted the WHO country office, who also alerted AFRO. And on the 3rd of September, a team was deployed to the field to investigate this alert. And samples were collected and sent to the INRB and tested positive for Ebola. And on the 4th, the Ministry of Health confirmed the outbreak and therefore declared and also activated the National Public Health Emergency Operations Center. So on the 5th of September, WHO had an internal grading. This is our usual practice whenever we have a confirmed outbreak. we go through a grading process. And so this outbreak was graded 3. It is a grade 3 outbreak. This is the highest grade where all levels of WHO are alerted, and so start the response to the outbreak that has been declared. So on the 6th of September, the WHO IMST, that is the incident management system, was set up, and we were able to mobilize resources which were sent to support the country in the response. So the current situation report that we have, I have indicated, is as of the 14th of September. So this timeline has not been updated as you can see. Next slide, please. Next slide, please, Amarash. Okay, so just as a quick summary of the cases that we have as of the date that I have indicated on the 14th, we have the cases with 15 deaths, and we have a number of probable cases that we are still trying to harmonize and be able to present to you in the subsequent updates. Just for us to note is the outbreak is restricted. It is within Bulape health zone, though we keep receiving suspected cases from other health zones as outlined on the slide. However, we have not confirmed any cases in any of the other health zones except Bulape. Next slide, please. Okay, yeah, so just to highlight the age-sex distribution of the cases, we have observed that there are more females affected in this outbreak, as always, may be related to their caretaking roles and responsibilities, where we have 54.9% females, and most of the cases are in the age group of 20 to 39 years. I believe this is the age group that is usually strong enough and taking care of the sick. And the same is also happening amongst the deaths. We see more females, and we have observed a high proportion of deaths in the extreme age groups. Next slide, please. Yes, so this is a geographical representation of where we have the cases. We have indicated that Bulape has that these cases are clustered in Bulape, which is a great opportunity for us for rapid containment if we sustain the efforts that are already ongoing. And the affected areas have several markets. That means there are people who come from outside into some of these affected areas. And this one is also a risk factor. If we don't quickly contain the outbreak, there is potential for spread. We also have information that these affected areas are mining communities, and therefore people come from different areas into some of these mining communities, and also therefore potential for spread. So for us to note is that this outbreak is still evolving, and we are also still investigating, and we've not yet been able to identify the possible source of exposure for the index case, and the transmission dynamics are not yet fully understood. That is why we have not indicated the epi curve, is because we are still investigating and trying to understand the transmission dynamics, and also trying to establish the possible source of exposure for the index case. Next slide, please. So a quick update on the response this far. Since the 4th of September, when the Ministry of Health officially declared the outbreak, and the WHO the next day graded the outbreak as grade 3, a number of activities have happened. We have had a total of 30 confirmed cases with 16 deaths. I think you can see that the CFR is still high. And unfortunately, we have had 4 healthcare workers infected, three of which died. And the outbreak is affecting Kasai province, which has a population of 3.5 million. And I think you can see that the population, the at-risk population is high, although we see Bulape as the main hotspot. Currently, we have 12 patients that are hospitalized in our designated treatment facility. This is an 18-bed capacity treatment facility, and we are almost running out of bed space. However, partners are working to expand the bed capacity. We've listed 654 contacts so far, and 20 of them have completed their follow-up period. So we are having currently, we have a 90.3% follow-up rate. And unfortunately, 5 of our contacts became cases. You can see that we have more cases, and we are saying that 5 contacts have become cases. So we are trying our best to ensure that our contact tracing is good enough so that all the listed cases, all the new cases are coming from the contacts list. But we are still investigating and trying to list as many contacts and expanding our investigations. And just like you will see in the subsequent slides, the place is very, very hard to reach. The team has moved for almost 3 days before reaching the area. So even navigation within the communities that are affected is very, very difficult. Okay, so we have so far 31 WHO experts that have been deployed in the field. Of course, we are working closely with our government counterparts. We are also ensuring that we have all the necessary supplies and all the logistics to make the teams able to move in the field and be able to conduct all the response activities. We are in the process of expanding the treatment facility capacity. Currently, efforts are underway to put up a 40-bed isolation facility. Groundbreaking has already happened, and the team is already working. Good news is we have so far 2 patients that have fully recovered and are waiting their second negative test results before they are discharged. I think this is very, very good and a very good plus to the case management teams and all the response teams. We've also tried to improve the logistics support. There is no water in this area, so the teams are depending on water tracking, but efforts are underway to sink a borehole that will be providing water to the treatment facility and also to the response teams. They don't even have accommodation. They are trying to find a place where they can be able to sleep. So we've also negotiated an airway bridge. So we now have a helicopter that is able to transport the supplies and also the response teams to the affected area. It is a very, very hard to reach area that even the field teams do not have transport. They cannot easily navigate into the affected area, and we are in the process of procuring motorcycles to ease movement of the response teams. Next slide, please. Also, enhancement of IPC measures. There's a ring IPC that has been initiated in the neighboring facilities. Safe and dignified burials are ongoing. Teams have been trained and different under the different religious denominations, ensuring that people are buried, the dead are buried in a safe and dignified way, following their respective religious denominations. There has been expansion of the triaging area to ease patient flow at the Bulape ETC, and also designation of improved IPC facilities. Not to forget our prevention of sexual exploitation and harassment, which is usually synonymous with such responses. We are strengthening this, and different focal points are in place to remind the response teams of their roles and responsibilities, not to exploit the communities that we serve. In terms of continuity of essential health services, the focal points have been identified in the different affected zones, and terms of reference have been developed, and the focal points have been oriented, and currently they have started collecting baseline data upon which they will start to implement the different activities based on the findings from the baseline. Next slide, please. In terms of challenges, yes, I've already talked about the risk communication and community engagement. There was a CAP study, knowledge, attitude, and practices study, to quickly understand the perceptions, the knowledge, attitudes, and practices of the communities, and this was very, very helpful, especially for risk communication and community engagement, and also for the other response activities. And so we have enough information to facilitate us as we move into the communities. So risk communication is ongoing, community engagement, because we have vaccination ongoing. So we also needed to get what the community thinks about the outbreak and what they think about the vaccination that is ongoing, especially for contacts and contacts of contacts. Next slide, please. So in terms of key challenges, I've already talked about the insufficient funding. You all know the situation with the funding, especially with the pulling out of the USAID funding, which was facilitating most of the response and preparedness activities. And also the operational and logistical barriers that I've already talked about. This place is very, very hard to reach. We also have no accommodation, poor road access, there's water shortage. And remember, in this area, the last Ebola outbreak in Kasai was in 2007. So all the colleagues had lost all the knowledge and all the skills that they previously had. So we are just rebuilding capacity in this affected area, thanks to government that has been able to repurpose health workers to support the response. There is very, very weak communication and internet connectivity. This has really, really affected the response activities. However, the response teams are exploring ways of improving at least the internet connectivity, working with government, and we expect by the end of this week this should have been improved and people will be able to communicate easily. Next slide, please. In terms of priorities, for vaccination, I've already informed you that we have already started vaccination using the geographical approach. And this is targeting contacts and contacts of contacts. We have received additional 45,000 doses from ICG, in addition to the 2,000 that were already in the country. In terms of surveillance, we aim to intensify case investigation, contact tracing, including in the neighboring provinces. You know, when someone dies in our African culture, we always get people coming from different provinces and coming to attend burials. So we cannot restrict ourselves to Bulape, where the epicenter. We also have to expand our interventions beyond. In terms of case management, we are working to expand the isolation facility, and also, just like I said, we're in the process of constructing a new 40-bed capacity treatment facility. Next slide, please. So in terms of, next slide, please, Amarash. For logistics, yes, we've already talked about water tracking. There has been a meeting between WHO, MSF, and UNICEF discussing how to coordinate the water tracking as the sinking of the borehole is happening. The procurement of motorcycles, this has already been done, and they will be delivered in the next, maybe today or tomorrow. And also establishment of a reliable communication network that we have already discussed, that the place is very hard to reach, and internet connectivity and GSM are not very good. In terms of readiness, supporting neighboring countries to finalize and implement their readiness plans, and also enhancing readiness at the regional office by instituting screening at the different entry and exit points. Next slide, please, which is my last slide. Amarash, please. So in terms of public health implication, I've already indicated that this outbreak remains a serious public health threat because the outbreak is still evolving. We've not yet finalized our investigation, so we do not know the extent of the outbreak, and we do not clearly understand the transmission dynamics. And this is something that we are trying to understand and close all the information gaps as soon as possible. We already have a high CFR, and we have high numbers of probable cases, and the risk of mistransmission chains is very significant. And so this is why we really need to sustain the efforts that are already ongoing. We have the poor road condition, which makes it very difficult to access most of the areas. And just like we indicated that we went in very fast and initiated the response activities, we already are doing the vaccination. We need to sustain these efforts, and we need to engage the communities. You all know outbreaks start in the communities and should be ended by the communities with their active participation and adhering to the recommended prevention measures. Thank you very much, and back to you, Mr. Moderator. Thank you.
Thank you. Thank you very much, Dr. Esther, for that very clear presentation. We are lagging behind in terms of time. I think cumulatively we need to catch up. We are behind by about 10 minutes or so. Colleagues, ladies and gentlemen, it is clear that we have an active outbreak. The good news is it is still confined within Bulapi Health Zone. a lot of work is going on, and we do hope that the surveillance system will work quite well in terms of identifying the cases, contact tracing, and the other teams dealing with case management, IPC, things will work very well. Our hope is that the outbreak will not go beyond Bulape. That is our hope. So we are going to go to the next presentation. So please keep posting your questions in the Q&A, or if you want to ask, we'll give you a chance at the end. So let me invite Dr. Ibrahim Mamadou to present on issues of readiness. Over to you, Dr. Ibrahim.
Thank you very much, Dr. Charles. Colleagues, I would like to reemphasize what Dr. Esther has said. This is an evolving situation, and there's a lot of gaps in our information. It's also in a very difficult context. And so we will continue to try and provide information as becomes available. However, as has been mentioned by Dr. Dick earlier, as the WHO, our rapid risk assessment at the national level is high, the regional is moderate, while global is low. That being said, this does not mean that a moderate risk assessment means we can take our foot off the pedal. It's incumbent on all countries within the region to activate several mechanisms, especially in your EOCs, to be on high alert mode. So we have, for readiness categorization of countries, as has also been mentioned, placed the countries that have direct land borders with the Democratic Republic of Congo as priority 1, alongside Congo that has the active outbreak. The country in focus is Angola, with a very close land border at the Kasai province, if you can see on my screen. However, even priority 2 and priority 3 countries have a lot to be doing. We can see from the table on your right, you should continuously, as a country in all of the region, be doing risk monitoring, while our priority 2 countries with the direct borders should be applying initial operational requirements and all our recommended readiness actions, as well as the risk monitoring, which was mentioned for priority 3. And we'll be coming into the recommended readiness actions. For priority 1, if outbreak is confirmed, which has been confirmed in Democratic Republic of Congo, of course, the response actions have been laid out, and that includes also monitoring the situation in surrounding districts within the country. So I would just want to say at this point that this categorization is dynamic. We are working very hard with a lot of other partners to gather more information, and the risk assessment or the country categorization can change. We have contacts with our sister organizations, the IOM, for population mobility information, and even ICAO for flight and aviation information. So when we go into readiness, we, even before the grading of the outbreak, had commenced readiness assessments in surrounding countries. So far in this round of assessment, we did do an earlier round of assessment you'll see shortly. We have about 70% of the countries that are surrounding DRC that have completed the assessment, while data is still actually coming in as we speak. Overall, the readiness score in the region is 64%, which in our categorization is still moderate. Over 80 would be adequate readiness capacity. Concerning, though, is that from countries that have failed so far, we're still seeing that the borders and IPC and coordination are still weak, as well as even public awareness and communication mechanisms. Comparing the readiness currently to the readiness we had done during the Sudan Ebola virus and Marburg viruses in Q1, there is a slight improvement. It was at 60% previously. with that caveat that more country data is incoming, so this current score can drop, as well as some of the countries are countries that did have the outbreak previously, so you would have residual higher capacity to respond because they have come out of a response. So some of the risk factors we have for international spread based on all the information you've heard previously from Esther and from our risk categorization, there are quite a few unmanned, unofficial, so open porous land borders with traffic moving between the countries, especially when we consider Angola, and we are very grateful for our teams within the field for providing information. There's also past displacements that have happened, and so we do know border communities are very integrated, and these may lead to heightened movement across the border. Cross-border economic activities are also a significant risk. There are mines, there is smuggling across the border, there's legal and illegal movement. We did say that these integrated communities, many of these borders to them are virtual. So this provides some context around the heightened risk in the area. We also have past conflicts causing some of the health systems infrastructure to be depleted. And so this also poses a huge vulnerability. There are large, as Esther has mentioned, the population, even in the Kasai region, is relatively large. And with mobility, in addition with different traditional cultural beliefs and behavioral attitudes, including fear that may arise from misinformation, this can really complicate the mix. Just to, this slide, we're not going to go into the detail, but just to emphasize that for border and points of entry and cross-border transmission of diseases, these are the IHR capacities that are relevant. Commendation to DRC really for, as Dr. Chamla said, implementing their Article 6 obligations using Annex 2 to quickly report. This really has given us a bit of a start in good time to attempt to contain this outbreak. However, I'd just like to point out here that despite the very large POE and border health assessment tools that we have, especially for IHR designation, which measures all the IHR capacities, we have worked on developing a rapid emergency assessment tool that picks out really a lot of, in the large groups of questions, the questions that are relatively closely applied to an EVD outbreak. This tool feeds off not the routine section of the IHR assessment tool, but the emergency sections and potential fake section of the tool. So this can rapidly be applied at your points of entry, and this will be shared as we share the materials after this. So we need to speed up in this presentation, so I will not be going very much in details into this. We have had in Q1 a similar webinar on this, and we will be sharing all the materials and slides. But just to emphasize that coordination as a readiness action is key for all countries in the region. Contingency planning for an imported FVD scenario, including what incident management and response planning at both national and subnational levels will be activated, including at your points of entries and borders. You do know that points of entries and borders are supposed to have public health emergency contingency plans specific for that border point. And of course, we encourage to test through simulations or at least a tabletop exercise. We need to urgently, as countries, increase the awareness on FVD. Encouragingly, we're hearing from many countries this interest to gather information. We have, as part of these materials, a lot of the guidance documents, and some of my colleagues will be mentioning on even message banks and other tools. Active surveillance and readiness of your rapid response teams are key, especially in collaboration with your communities and partners. Apart from border areas, as well as in neighboring districts. And a country risk categorization would be ideal at this point. Many countries have already commenced using country-specific risk assessment tools to map out their highest risk districts. This serves as a resource prioritization exercise, which can assist in saving valuable resources which are scarce, as Esther has mentioned. This is also the time to start pre-positioning procured personal protective equipment. You need to do an inventory. I have colleagues online that will, if you have questions on that, guide on how to calculate these supplies. Technical assistance, as we have mentioned, we have, as an organization, several with our sister partners, several guidance and training tools. I'll be showing a few of them at the end of this presentation. I will not go into the details through our 5C HEPAs of all the pillars readiness actions. I'll just touch on a few just to highlight. We can always come back to any gaps you want to know about in the discussion section, but in coordination, as we've mentioned, you need to have at least task forces or committees coordinating and facilitating implementation of your readiness measures. The local level also needs to be activated. You need to retrain your coordination and as well as ensure your SOPs are up to date. Ensure you also have up-to-date cross-border SOPs and memoranda for sharing information. As we continue to say, test, and test. All these plans, we need to test their functionality. In surveillance and early warning, we, of course, have a WHO case definition. You can adapt and disseminate in all facilities, borders, in all congregation points in the country. Retraining of your surveillance workers on EVD and active case search, including orientation to your community focal persons. Ensure you have a strong pool of contact tracers. Most countries have these capabilities from the COVID and Mpox fakes and pandemic. So it's time to orient them and have them on the standby. Ensure your early warning systems, including software like EIOS, event-based surveillance, functioning, especially in your targeted high category districts, provinces, states, prefectures. Ensure there is capacity to investigate all alerts within 24 to 48 hours, which includes establishing communication channels with even One Health structures. You've heard that there is amplification in animals. They are also a risk. Your RRT in each high-risk district have at least one trained RRT with adequate PPEs. For lab readiness, we won't go through this, but ensure you have procured and prepositioned at least real-time PCR testing kits for filoviruses and conduct refresher training for lab personnel. Update your SOPs and ensure your data management system is up to date. Try as much as possible to ensure you have trained personnel for shipment, if needed, to regional laboratories with IATA certification. Of course, needless to say, you need international MOUs at this stage with regional labs that can support and, of course, procure triple packaging material. For One Health, as we have said, ensure that integration of intermediate host population surveillance into your surveillance system to pick up early signals is possible. Clinical case management, very important. You need strengthening of your IPC structure, coordination structures. So what has been established, you reactivate. Ensure you have clear referral pathways to at least one dedicated isolation unit that is reachable by ambulance within 2 hours. Have one at least ETU with trained management teams, and ensure you have PPEs and basic supplies for at least 5 MVD cases. Ensure your ambulances are functional and dedicated and trained teams are present. It's not enough to say you have the ambulances, but are they functional? Do they have a driver? Do they have, for example, batteries? You need to test all of these systems. We have a lot of SOPs and case management tools that will be made available. In high-risk districts, ensure that rapid assessment, the scorecards for IPC and WASH are performed. Ensure also IEC materials are visible. Ensure you have screening and triage facilities, hand hygiene facilities. Ensure you update on specific IPC trainings, access to safe water and hygiene at your facilities, and of course, waste management and disposal. This is the time also to develop your health services continuity plans because of the risk of the increased numbers disrupting your routine facilities. We've seen this in COVID quite at a huge proportion. We just want to emphasize assessment of health facilities and testing health system resilience through facility-based exercises as well. Ensure you also have surge capacity for where you will get those extra personnel if numbers exceed expectations. But also ensure you have mechanisms for the welfare of personnel, including your psychosocial support and adequate IPC. For OSL, we have our colleagues online, but you need to start to quantify essential stock. There is a tool that can guide on that. We will be sharing. Where are your storage and transport capacity? What is your cold chain capacity? You have heard that vaccination now is a countermeasure option for Ebola. Ensure you have coordinated platforms for these health logistics, and you monitor pipelines. If need be, rehabilitation and modification of existing facilities to meet patient flow should be done at this time. As we have been mentioning vaccination, there are multiple countermeasures that are in the pipeline. So countries need to ensure that they have predetermined regulatory and ethics approvals to test these if there is an importation of cases. We do remember during the SVD, Uganda is a good best practice. They did have protocols already pre-approved, which led to very rapid deployment of new medical countermeasures. Of course, once available, you need plans for vaccination of frontline health workers, as is ongoing within the DRC, and we're hoping will help us stem the outbreak. For risk communications, we can't go into the details, but ensure you have coordination mechanisms, listening systems are mapped, and infodemic management, quite important to prevent hesitancy to all your medical countermeasures. Ensure you have the update of your appropriate communication channels, and my colleague is online to discuss about the tailored messaging. A very extensive message bank does exist and can be shared. Of course, you need to dig deeper into social and behavioral data and feedback from the communities. Work with your local networks of dedicated RCCE colleagues. Where possible, deploy anthropologists. For WASH and IPC, I'll just mention here that, as was mentioned by Esther, there's the IPC ring approach. The link is here, which you can use, but ensure that even high population areas have robust IPC hand washing, like schools, public places. Unfortunately, we have lost a lot of the capacity we built during COVID. This may be the time to reactivate all of these hand washing stations that were in extensive gathering places. For SDV, safe and dignified burial, you need at least medical supplies for your teams to manage at least 5 filovirus cases. Ensure they have trainings, they have their PPEs, as well as bodyguards for at least 5 burials as readiness. I also have your SOPs updated for household decontamination. Now, I'd just like to, as part of POE and cross-border, emphasize on certain things that are part of the core capacities for both preparedness and readiness. You will need to enhance your information sharing and cross-border surveillance collaboration between neighboring countries. Thankfully, as we are following up with surrounding countries, we're hearing of quite a few planned cross-border information sharing meetings. But as we get more information around the population mobility, you will also need to be mapping porous areas, areas of unmanned borders. Screening equipment, also quite encouraging. Quite a few countries are updating that they are already deploying temperature screening. You need to update your POE personnel on the signs and symptoms to look for, as well as referral pathways. Of course, POEs should be integrated into your early warning and surveillance networks for early notification to central levels, so including your alert systems, including the EIOS and hotlines. I have mentioned cross-border movements mapping. This is an area that is continuously gaining prominence as we have multiple outbreaks. Update your POE specific contingency plans, and this must, and very importantly, include its surrounding district and the health facilities for referral mechanisms. As you know, management doesn't happen at the POE, but appropriate, safe areas for interviewing, both primary and secondary holding units, and then rapid evacuation to isolation facilities pre-designated should be emphasized with, as we mentioned earlier, trained ambulance teams and appropriate equipment. Many POEs that we have done an assessment in, we find that there are the PPEs. However, you find because they are not used frequently, most times we do a designation assessment, they are expired. This is the time to check that you have PPEs that are valid and can be used. This is like having a bulletproof vest in a battle and it doesn't work. You will be shot. Risk communication, especially in border communities, to dispel rumors as well as encourage trust in the surveillance system is extremely key. As we're mentioning, a lot of the borders are informal, so your line of defense may be your border community surrounding the affected districts or surrounding travel corridors, congregation points. The border communities need at this stage to be able to report into the formal community surveillance systems. So in conclusion, this model is from our sister agency, ICAO, and it's borrowed from the aviation sector. It's just a reminder that preventing international spread really is a combination of a lot of multiple measures. This is the Swiss cheese model developed from their safety in aviation models, but applied to health in the COVID pandemic. Some of these layers you see, well, all of the layers have flaws. They do have holes, from your risk assessment to hygiene and health screening and declaration. These are individual responsibilities, while we have a lot of shared responsibilities as countries, including public health measures, border control and screening. You will notice that in the Swiss cheese model, one of the layers here, you can see communication and education. We have a mouse eating away at this layer. This is information, infodemics, which will deviate from proper health-seeking behavior. But if you have all of these readiness capabilities in sequence and in combination, you will find that even though some layers fail, the hazard can be prevented through a combination of multiple of these layers. It's quite a good picture of what we are encouraging countries to do. Just to remind you, as we said earlier, there's quite an extensive area of guidance documents. We do have, you may be previously familiar with the filovirus National Readiness Assessment tool that is going to also be shared following this webinar. We also now have a subnational level tool, which can be applied to high-risk districts to enable them to strengthen their readiness by assessing their gaps. For the POEs, as I mentioned earlier, we do have the POE rapid assessment tools for emergencies for filoviruses. We have tabletop exercises, scenarios that have been translated into English, French, and Portuguese ready for countries to use as we share. We have a cache of all our SOPs, guidelines, and tools, including training materials. And we have online training courses that you can utilize to upskill your health workers in the countries. Just to emphasize that we also have some broader frameworks for preparedness in viral hemorrhagic fevers. These can be used either now or in peacetime to assess your general preparedness as we move forward, knowing that readiness is much more imminent. It's a state of specific functional capabilities that need to be fast-tracked and activated in anticipation for a imminent or priority or even simulated threat. And as we have seen through these presentations, the whole continent is at risk of this current threat. Also coming later, WHO will be releasing our point of entry and border health framework for the African region. So I will hand back to the moderator. I will stop here and we're open for discussions.
Thank you. Thank you very much, Ibrahim, for that very detailed presentation. And I want to assure our colleagues that the presentations will be shared so that they can be able to go through them and be able to digest some of the information that has been provided. But in a summary, Ibrahim has really emphasized on the need of readiness. And when we talk about readiness, it's about a situation whereby there is an imminent threat. And for this case, we have Ebola in DRC, and therefore all the neighboring countries, they need to ensure they have put in place their readiness measures. We have already shared with these countries the tools, the guidelines that they need, the anticipatory actions, focusing on the 5 C's. Basically, in a summary, the 5 C's is the collaborative surveillance, it's about the community protection, it's about scalable clinical care, it's about coordination, it's about countermeasures. So look at them from that broad perspective and ensure that we do our readiness properly in those areas. We all know that diseases don't respect borders. We know that they don't need visas, and therefore we need to be ready. The last slide, you saw the multi-layered approach from our colleagues from ICAO, which is very, very good, telling us that we need to put several measures in place to be able to contain such an emergence. We don't have one single silver bullet. So we must implement all these to ensure that we contain and also prevent further spread. I would want now us to go to Q&A. We are 10 minutes behind. We'll first of all allow people who would want to be given the platform to raise their questions. We'll give you a chance. Then we'll also look at the questions in the chat box, in the question Q&A. And I would ask Dr. Bukari, if you are there, you can begin to look at those questions that are in French. Yeah, so let me start with Lisa Tool, then we'll go to Usman. Over to you, Lisa Tool.
All right, good afternoon. Thank you very much. Excellent presentations by Esther and Mamadou. Very clear. I wanted to ask the timelines. Esther made it clear that they are not really clear. I don't know whether more can be done to provide the countries with these timelines. In cases you want to do retroactive case search, to step up surveillance and reporting efforts. I don't know what else can be done. And then I also need some clarity around the measures put in place to ensure tracking. You mentioned tracking of population movements at crossing points and points of entries for us to be able to ensure You track individuals coming from these endemic points real time. And also, number 3 is to ask our colleagues in ICAO what has been done actually to step up IPC, especially during flights to and from any point in DRC. Thank you, and well done to all of you. Thank you.
Thank you. Thank you very much, Lisa. Let's go to Usman.
That was Usman. Risatu did not ask a question.
Sorry, come up again.
The last question was by Usman. Risatu did not ask a question.
Okay. Lisatu, are you there? Okay, let's go to Luisa.
Boa tarde, obrigada pelas lindas apresentações.
It's Luisa speaking. Amarachi, can you hear Luisa?
No. She's not speaking.
I don't know what happened to her. We can always come back to her. Let's go to Saila.
Merci pour cette brillante présentation. Je me présente, je suis Dr Sila Sekouna, je suis médecin santé publique de nationalité guinéenne. Merci. On avait vu comment on appelle, l'itinéraire de cette dame, le cas index, mais moi j'aimerais poser la question sur la chaîne de transmission de cette dame. Comme la date qui a été décrite, c'est allant du 10 au 20, mais en dehors du 10, quels sont les événements de santé publique qui ont débuté sur cette date? On sait que j'ai participé à l'épidémie Ebola en 2019 en RDC. On a eu beaucoup de cas de suspicion des avortements aussi chez les femmes qui sont testées après positifs au virus Ebola. Mais quels sont les facteurs influençants chez cette dame par rapport à la date que vous avez dit? Est-ce que à partir de cette date, après cette date, quelles sont les actions de santé publique qui ont été effectuées autour de cette dame? Je vous remercie.
Thank you very much, Sheila, for that question. Let's go to Fabian. Fabian Ilunga, you have the floor.
He's muted, I think.
I think he's muted. Okay, fine. We can begin responding to those questions, then we'll come back for another round. Esther, you have some questions on timeline and also the issue of the public health events that could be occurring that between 10th and 20th events, let's call them events that could be happening during that timeline. Then I think, Ibrahim, you can also add or weigh into the question from Usman on issues of tracking of movement, population movement, what is going on. So I give you the floor, Esther, then Ibrahim, you can make an addition.
Yeah, thank you. Thank you, colleagues, for the questions. And I will attempt to respond. If there's any other colleague online who would like to weigh in, you can come in. So we've identified the movement of this lady from the time that she started experiencing signs and symptoms, that's on the 10th, until when she died. Unfortunately, the early warning system did not capture this until when the lady died from Bulape General Hospital. This is previously we've been receiving VHF alerts, but these were from different provinces, and we never ever received any VHF alert or any alert of any epidemic in this Kasai region. However, this is something that we can still look at and try to explore as we continue with our investigations in the communities. And also regarding the possible risk factors and key drivers of transmission, that is if I have interpreted your question very well. We actually have not yet been able to identify, except the super spreading event of the burial of this lady. She was buried by the community and by quite a number of people from different villages around. This is what we were able to capture, and this season is farming season. I think it is rainy season, so people are planting, and planting, especially the communal agricultural activities, bring people together. So these are some of the key events or gatherings that have been identified, plus the markets. We have indicated that this area has several markets and collects people from different zones. So these are some of the major events that we have been able to document during the investigations. However, investigations are still ongoing, and we shall actually purposively ask this question so that the teams can consider looking at which other gatherings have happened and which other major events have could have predisposed, especially the index case and many other cases that we maybe have not yet been able to identify in the communities. Thank you, and back to you, Dr.
Okay, thank you very much, Esther. Ibrahim, very briefly on population movement.
Yes, thank you very much for that question. It's a key one. As we did say, there's quite a few gaps because of these unofficial borders that are porous. So the population mobility mapping framework is really in the remit of our sister agency, the IOM, as well as some other partner organizations that do POPCAPs. We do know already that their team is on the ground within the DRC. This exercise is already commencing. However, I would just try to emphasize, number one, I have put in quite a large cache of guidance documents around POE in the chat. We are also going to be sharing with you very big folders on guidances. It's just to remind colleagues that the colleague that asked the question asked what ICAO is doing around monitoring implementation of capabilities at the POEs. The responsibility ICAO bears really is about providing capacity building, providing guidances, as well as information. We are getting information from ICAO. However, we have established through the MPOX and previous outbreaks a joint working mechanism with IOM, Africa CDC, IGAD, so many other partners we will be trying to support member states to strengthen these capacities, but at the end, these capacities are responsibilities of member states' governments. We have the tools, we have the guidances, and these are things that really will be required at your specific points of entry. I've shared the tools around screening for filoviruses, the guidance around preparing to screen for filoviruses, as well as many of our tools, as I mentioned earlier, we have extracted out of the IHR designation of POE tools, specific a rapid version that you can use to check your airports, your ground crossings, if they have at least the minimum capacity to detect and respond to a potential importation. So member states, please do reach out to your country offices. There are many guidance documents we will be sharing after this meeting, and we will also be trying to establish a forum where especially border health and POE pillar members in the countries, we can share information as we move along. There is a lot of guidance documents to member states.
Okay.
Thank you, and back to you, sir. Yeah.
Thank you. Thank you very much, Ibrahim. We'll want to take a few questions before we close this webinar. First of all, those who have raised their hands, then I will also be asking Dr. Bukari to sample a few questions in French as we come towards the closure. So Jean Matthew, are you there? And if Fabian, you are back, please, I'll give you the chance. Jean Matthew?
Oui, je suis là. Est-ce qu'on m'écoute?
Ah.
OK, je suis Dr Ndaliko, depuis Kinshasa, en RDC. Je remercie infiniment les deux présentations complémentaires d'Esther et Ibrahim. Alors, ici, je me place au niveau d'une prévention globale, parce que définitivement, la maladie à virus Ebola est une zoonose. Et donc, la trilogie homme, environnement et animaux par rapport à la stratégie One Health, elle a son pesant d'or à ce niveau. Je voudrais savoir, cet épisode est le 16e pour la RDC. Et donc, la rupture des pratiques entre les hommes et les animaux est mise en cause de façon définitive. À mon niveau, je pose la question de savoir si l'OMS, avec tous les autres partenaires, nous avons déjà mis en place un système de surveillance de cet environnement, notamment au niveau des réservoirs potentiels qui sont déjà connus parmi les animaux sauvages, parmi les oiseaux sauvages, comme les chauves-souris. Est-ce que nous n'avons pas un minimum d'indicateurs à surveiller, peut-être par rapport à leur comportement, le comportement des animaux, peut-être aussi par rapport à leur mortalité, parce qu'à ce niveau, je crois que quelque part, on a déjà décrit le fait que les animaux malades ou les animaux qui sont morts d'eux-mêmes en brousse deviennent dangereux par rapport aux chasseurs. Est-ce que nous avons un système de surveillance de cet environnement pour une prévention beaucoup plus globale? Merci. Over to you.
Thank you very much, Dr. Dalinko. Fabian, are you there? If not,
Dr. Charles?
Yes.
Yes, I have, there is a question. I have a comment with 2 key recommendations for accessibility.
Yes, I'll be coming to you. I've seen the
Okay,
question.
thank you.
Yes. So, Misambu, I give you the floor. Then we'll go to the questions that have been put down. Misabu? Okay.
He's muted.
Yeah, he's muted. So let's move on.
j'ai ouvert, je disais, je suis Serge Missambou, je suis en RDC, je suis éco-épidémiologiste. Ma préoccupation est de savoir, rejoindre un tout petit peu mon prédécesseur. Entre guillemets, les positifs des cas Ebola conservent le virus une fois guéris jusqu'à plus de 518 jours, je crois bien. Je me demande, quelles sont les mesures qui sont prises pour le suivi de ces post-Ebola une fois guéris pour l'épidémie, la 16e épidémie de la maladie à virus Ebola dans la zone de santé de Boulap. C'était ça ma préoccupation. Je suis saisi?
Yes, I believe your question is clear. So my colleague Esther addressed the question from Dr. Daliko, then Ms. Sabu. Then there were also some questions in English that were posted there just to sample a few. Elvis is asking, considering the intensified surveillance, what systems have been put in place for community-based surveillance? If you have a response to that. And my friend, Victor Coker from Sierra Leone, wants to know whether the infected health workers are from the same health facility. Please take note of those questions and respond. Then I'll give the floor to Dr. Julien to respond to RCC question. Then Dr. Bukari, you can sample one or two questions written in French. Then I think we'll go towards the end. I'll give my colleague Carla, OSL, to say something on prepositioning, then Dr. Dick will finish. So please be brief, colleagues.
Yes, thank you, Dr. Charles. Let me attempt to answer the questions. In response to whether the infected health workers are from the same facility, yes, they are from Bulape General Regional Referral Hospital. And regarding involvement of communities for community-based surveillance, yes, the communities are part of the response. And even before that, as part of IDSR, we had the community health workers participating in surveillance, in routine surveillance. So the communities are actually, for contact tracing, it is the community volunteers who are undertaking active case search and contact tracing. We cannot impose strangers on the communities. So it is the communities that are really participating in these response activities, reaching out to the affected families, conducting risk communication and community engagement, and also looking out for new cases through active case search, and also monitoring the contacts. Regarding involvement of the animal health sector in the response, and also being part of routine surveillance. The current response, we have sent a multidisciplinary team that is in the field to investigate. So we are not only limiting ourselves to the human health sector. We also have the veterinarians who are also undertaking their own investigations, and findings of all these investigations will be used in building an early warning system. I believe ecological studies have already started. If not, there are plans to conduct these ecological studies. And I believe in DRC, there is a One Health platform that coordinates response, investigation and response, and also setting up early warning systems for zoonotic diseases. So this is something that WHO has already thought about and has always been building capacity for under the One Health platform. Thank you very much, and back to you, Mr. Moderator.
Thank you very much, Esther. Julian?
Merci beaucoup, monsieur le modérateur. Je vais parler en français. Et il y a une question qui demandait quelles étaient les désinformations qui étaient en circulation. Donc, suite à l'étude CAP rapide qui a été faite, dont Dr Esther Mouangouzi a parlé dans sa présentation, la plupart des perceptions, je vais juste donner trois principales. C'est que Ebola, c'est une affaire de blanc. C'est la rumeur persistante qui suggère que l'épidémie est une invention des étrangers pour des raisons économiques, politiques. L'autre rumeur, c'est que les équipes de la riposte volent les organes. Et cette croyance alimente la peur des centres de traitement et justifie le recours aux guérisseurs traditionnels. Et l'autre, c'est que le vaccin rend stérile. Il y a une méfiance profonde envers la vaccination, perçue comme un complot pour contrôler la démographie locale. Mais depuis une semaine, parce que cette étude a été faite la semaine passée, les équipes de la riposte, notamment l'équipe de communication sur le risque et tous les piliers, ils ont révisé le message et vraiment répondu à ces rumeurs qui sont en train de circuler. C'est ce qui a permis qu'il y a désormais plus de malades au centre de traitement, 12 comme le docteur Esther nous a dit. Et il y a l'engagement des guérisseurs traditionnels et des jeunes est en cours. On a aussi développé, l'équipe de communication a développé des outils de communication qui sont en lingala, une des langues locales parlées, mais aussi la langue pende. Et les informations circulent à la radio locale auprès des leaders coutumiers, des leaders religieux dans les langues locales et il y a un meilleur engagement à travers les agents de service, les agents de santé communautaire et les jeunes, parce que les jeunes, il y a beaucoup aussi qui circulent dans les réseaux sociaux. Donc, on a beaucoup impliqué les jeunes, mais ce travail n'est pas suffisant. Il faut qu'on continue à cet engagement communautaire à la base, engager tous les volontaires à travers notre partenaire de la Croix-Rouge pour pouvoir continuer de donner les sensibilisations porte à porte, répondre aux questions, aux préoccupations des communautés, y compris sur l'ensemble des opérations de la riposte. Le reste des questions, j'ai apporté les réponses en français dans le volet questions-réponses. Merci beaucoup, Dr. Charles. Over to you. Thank you.
Thank you. Thank you very much, Dr. Julien, for that response. The questions in French, I have the translation here. I'll just pick two or three. One is, what actions are being taken in the surrounding areas? How many days of follow-up are planned for contact tracing? What psychological support is planned for the affected family? What about active case finding since the area is inaccessible? Then the other one, those questions are from Hamadi Baraka. Then we have from Shama Shanga. Hello, is this presentation up to date? Is the geographical situation of confirmed cases? I notice that AS Bambalai, I don't know how to pronounce that probably, still has 0 confirmed cases, even though it has been in the dance for more than 48 hours. I don't know if I am mistaken. Then Paul is asking, what is the most critical aspect typically experienced during an Ebola outbreak response? Then lastly, from Deborah, thank you very much for the presentation. Neighboring provinces are developing preparedness plans. Should they also activate the EIRs, or will we have to wait until case appears? Esther, I think these are questions directed to you. Try to be as brief as possible. We have already gone beyond by 6 minutes, and I would want to give Carla to make a comment on supplies, then Dr. Dick will conclude. Over to you.
Thank you very much, colleagues, for the questions. I will start with the last question. If the presentation is updated, at the beginning, I gave a disclaimer that this report, the presentation that we have, is as of the 12th of September, and this is from the Ministry of Health. This is the latest situation report that was shared. If we've had cases in other areas, the Ministry of Health has not put out this situation update. Regarding the reporting of suspected cases from the neighboring areas, yes, we have intensified our active case search efforts through the community health workers, the health workers in the different facilities, and therefore we are receiving suspected cases from everywhere, and all these samples are collected and tested, and we have been receiving test results, negative test results from all those suspected cases that are reported. I think that's all I was to respond to. Thank you, Anne.
Thank you very much, Dr. Esther. So, Carla, please, you have the floor. Issues of prepositioning of supplies, very critical. We are dealing with an outbreak in a remote area. Please, you have like 2 minutes, then I'll invite Dr. Dick.
Okay, thank you. Thank you so much. I just want to briefly talk about the preposition of stocks that is required, but also what type of stock should be required. For the EBD, we're looking into PPEs, which is the main item that is needed for health workers to take care of the patients that will be coming suspected or confirmed cases. And we use the VHF 500 kit, which is what we have deployed to DRC and what we have in preposition in Dubai, in Uganda, for example, or in Rwanda. Now, how many of these kits are required usually is the question, because we don't know how complex or how big the outbreak will be. So we're looking into at minimum of 5 of these kits that will be taking care of the health workers, taking care of the patients. So we're looking at 10 patients for 10 days to be taken care of with 1 kit. Now, also, when we're looking into what other items are required, we have, and if can just share for a few seconds, I hope you can see if we can have or use this this tool, which is the Essential Items Estimator tool. Can you see it?
You haven't shared yet, Carla. You haven't shared yet.
We can't see anything.
It's
Yes,
coming
it's
up
coming.
now.
It's coming.
Can you see it now?
Sure.
So perfect. So this is the Essential Items Estimator tool that we are recommending to use. It can be used for different types of outbreaks, but now I opened the one that is for Ebola specifically, and you here can see the types of PPEs and the quantities that are required based on the input, which means how many number of beds, how many number of health workers will be taking care of these beds, and for the period that is required. Also here we can see human resources needed, medical devices, medicines, and wash and logistics items that will be required. And I think I will stop there because I have more to talk about the supplies, but the time is limited. Thank you.
Thank you, Carla, for your understanding. I know you have a lot, but time is not on our side. We have gone beyond by 10 minutes. I think at the top of the hour, we had more than 400 participants from different member states, partners, WHO. We'll keep the conversation going on, and therefore it's my pleasure now, and also we shall share the materials with you. It's my pleasure now to invite Dr. Dick Chomla to conclude this webinar. Thank you. Over to you, Dr. Dick.
Yeah, I really appreciate everybody for your attention and engagement in this webinar. I think we had an excellent exchanges, excellent questions and clarifications from our teams here. And I agree with the moderator. I think we should still continue the conversation. I think it's critical. I think we've all heard the outbreak is still evolving, and I think it's still it is upon us to really actually have our eyes open and our ears open. Yeah, I think I only have 3 messages to leave you with. WHO is employing all hazards approach in its emergency management. At the time we are talking now, the readiness response of Ebola is a grade 3. We have other 2 grade 3 in which are also present in the DRC, and I'm talking of cholera and mpox. As there is therefore the risk of international spread is also as we have to consider. On the point two in which I need to also talk with you is the issue of Ebola legacy. I think I'm sure Esther also have taken here on the issue of how to sustain the response. However, overall big picture here is how our response will actually leave behind the structures or able to strengthen capacity need to prepare and response in the future. As a result, I think you have talked of communities. I think communities are a critical part, but overall we have to think how emergency preparedness and response is able to strengthen overall health systems. And on the last point, I need also to end up here with you, is that we are now only 3 days away from entry into force of IHR amendments. So on Friday is official date of all our member states to start implementation of amendments of international health regulations. As a result, I hope issues of the declaration of the outbreak, our member state will be prioritizing it. And how it's happening now, you have heard in the beginning, our response, it was swift and rapid. It was because of a compliance of IHR amendment in which our member state, the DRC has done. I will end up here and really appreciate your attention, and I'm returning to you, Charles. Over.
Thank you. Thank you very much, Dr. Dick, for the 3 key messages that we can take away from this meeting. Very, very important, reminding us that the IHR amendments are coming into force, and therefore member states need to look at what they need to do. And also, these outbreaks should leave our systems better than the way they found them. That's about resilient health systems. So thank you very much for those key messages. Colleagues, ladies and gentlemen, thank you very much for your patience. We have gone beyond by about 14 minutes, but I think it was worthy. Thank you. Merci beaucoup.
Thank you very much.
And thank
Dr.
you also
Charles.
to our interpreters for a job well done, and all our panelists. Thank you.
Thank you, Mr. Moderator.
Yeah.
Merci beaucoup. Gracias. Thank you.
Thank you, colleagues.
Muito
Julian,
obrigada. Yes.
are you still there? Please stay on.
Yes.
Do you mind turning on your camera if you don't mind? All right. Okay, bye, colleagues.
Bye. Thank you.